name is Batia, and this is the Cat 3 video. So first I'm going to start off with the psoas and camera arms. And you point your fingers towards me, and without looking, I'm going to do this. And then I'm going to check. And my patient has a left short, so I'm going to stand on the contralateral side and have the patient bend their knee. And is it okay if I reach across and stabilize? And I'm going to find their psoas muscle. And I'm going to have my patient breathe in and breathe out, and breathe in and breathe out, and breathe in and breathe out. And I'm going to go. Okay, so next it will be prone leg length analysis. I can have you flip over face down. I'm going to have my patient separate their ankles about 14 inches and then resist and relax. And I'm going to see which medial malleolus is superior, and it's the right one. So that will be my short leg side. Next I will be doing the glute fiber analysis. So I'm going to find the PSIS and correlate that with L5, and I'm going to palpate around it and look for all the points up to L1. And I'm going to see which one is tender, and I'm going to come back to it after the Cat 3 analysis and see if it's still tender, then I will treat it as a trigger point. Next, I will palpate for tenderness in the calves and thighs and glutes, rectus-spinae, and can I have you face this way? And this is going to be the temporal sphenoid, so I'm going to palpate for tenderness here. And was any of that tender? Okay. Which one? Oh, okay. So, sit. And next I'm going to do the SOTO. So that will be a step out, two out. I will be sitting down for this, and my indication for this is sciatica. Also, this is a both diagnostic and therapeutic step for piriformis. So I'm going to have my patient step out, and then I'm going to bring their toe out, and I'm going to hold it for 10 to 15 seconds and bring it back in, and ask the patient if it got better or worse. If it got better, then it was piriformis. If it got worse, then it was a sequestered disc. Next, I will be doing the passive blocking. So my patient is going to have the board about 4 inches above their iliac crest, and the sternal roll is going to be under their chest. And I'm going to take the block and place it on the short leg side under the greater trochanter. And since it's a passive blocking, I'm going to ask my patient if they have any knee problems.
No.
Okay, so it's going to go under the greater trochanter here. And then on the long leg side, I'm going to go under the ASIS, and it's also going to face 45 degrees inferior. And do you have any knee problems?
No.
My goal is to reduce pain, and the maximum blocking time is going to be 30 minutes. And during this time, I'm going to continue with block augmentation. So next, I will be starting off with block augmentation, and the first is going to be posterior iliofemoral ligament. So my patient is going to be prone, and I'm going to come in and internally rotate and see which one's restricted. And it's my patient's right side, so I'm going to come in 1 inch superior and 1 inch posterior to the greater trochanter. And since I have a block here, I will remove it. And I'm going to do a double thumb toggle towards the opposite obturator foramen. And then I will replace the block. So next is going to be lumbar vertebral derotation. So this will be correlating with the cervical indicators. So if my patient has C2 TVP tenderness, I'm going to L4 spinous process, and I'm going to lift my patients like to 90 degrees, and the line of drive is going to be lateral to medial. So as my patient inhales, I'm going to go lateral to medial as they bring their knee in, or their leg in. And the next will be the lumbar vertebral inferiority. So it's going to be the same thing, except if my patient has a C2 spinous process tenderness, I'm going to come down to the L2 mammillary and bring their leg up again, and at inhalation, I'm going to press I to S. Okay. And the next thing is going to be the acetabular step. So I'm going to find my patient's acetabulum and look for tenderness. The indication for this is going to be either acetabular pain or sciatica. So I'm going to come in and palpate for nodules while I internally and externally rotate, and then I'll be goading at that time. Okay. So next is orthopedic blocking. So I'm going to look at which side my patient's lumbar has rotated to. So let's say it's on the right side. So I will pull the block out on the right side, and I will let the gravity and the patient's position and the blocking take care of rotating the vertebral body back into position. And then I will place the block back down. And throughout the block augmentation, the patient will be tractioning their arms to the table, and they'll be tractioning forward. So next is sciatic traction. So as my patient is tractioning forward, I'm going to come to the side of the sciatic leg. So let's say it's on the right side, and I'm going to grab above the ankle and traction it. And while my patient is, let's say, grabbing onto the head of the table, and I'm going to hold it for 5 to 10 seconds. And I'm going to continue doing this until the pain either goes away or tractioning results in no more improvement. Next, I will have a lovely imaginary assistant come in and traction the leg. And while they're tractioning, I will find the involved segment, and I will commit to the spinous process and push I to S during traction. Next is going to be the sitting disc technique. So I'm going to have my patients sit, and they will be seated on a SOT block or board. And can you just face that way? So I'm going to contact on the involved spinous process, and I'm going to have my patient tuck their chin in to the chest, and as they inhale, I will need my patient to flex, and I will be pushing I to S. And as my patient exhales while tucking their chin in, I'm going to have them extend, and I'm going to be pushing P to A. Okay, and the next is going to be side posture. Okay, so my patient is going to have their sciatic leg down, and the spinous process is also going to be facing down. I'm going to bring their leg in, I'm going to stick in between, and contact the mammillary, and I'll be pushing P to A for the spinous process or rotation. And if there's a wedge and I'm trying to correct that, then the line of drive is going to be I to S.